For this next session of the Covering Rare Diseases Fellowship Program, we're going to be talking about the issues of diversity and inclusion and ethics in the realm of rare diseases. We're joined by two speakers who will help us unpack those issues. The first is Marcia Treadwell, and she's the director of the Northern California Network of Care for Sickle Cell Disease. And she's a co-chair of the Diversity, Equity, and Inclusion Council for the University of California, San Francisco's Benioff Children's Hospitals. And then she'll be followed by Megan Halley. Megan is a senior research scholar at the Center for Biomedical Ethics at Stanford University. And she's also the mother of a child with a rare disease. Thank you both for joining us today. Marsh, I want to start with you because, as we mentioned before joining, the words diversity, equity, and inclusion can sometimes raise more hackles than understanding in the current atmosphere in the US anyway. And so I want you to help us understand what those words mean in the realm of rare disease advocacy, research, and treatment.
Absolutely. So let me share my screen. And I am going to be talking about diversity, equity, inclusion, and anti-racism in the context of health disparities related to a rare disease in the US, sickle cell disease. So I want to thank you so much for this opportunity. These are my disclosures. And what I'd like to do today is help you to understand disparities in health resources and outcomes for the population with sickle cell disease that indeed is embedded in the context of structural racism in the United States. And then I'm going to help you to gain familiarity with some strategies to address health disparities with the goal to achieve health equity for the population with sickle cell disease. So this quote from the National Academy of Medicine, I added the piece about changes needed, not just from the bedside through to health policy change, but as well starting at the bench. So if we recognize that we bring our diverse perspectives, then we recognize that even what we choose to research, that is what drugs we study, what mice we study, and so on, the issues of diversity begin at the bench. So sickle cell disease is a very complex disease. It affects the red blood cells. So everywhere that blood flows can be affected by sickle cell disease. And I can't emphasize enough, again, that it is a very complex disease, which is underestimated in terms of how it can affect the brain, the liver, the heart, the bones, the eyes. People know about the pain that sickle cell disease can cause, but it can cause these other issues, and again, anywhere that blood flows. And further, because most people with sickle cell disease in the US are Black African American, and many as well are Hispanic ethnicity, then these individuals are impacted by negative social determinants of health. And so these communities may have challenges with even accessing healthcare, preventive primary care. Neighborhoods and built environments may not be the healthiest. Social and community context can really change so that people can become isolated as they have to move away from their communities. Economic stability, where populations don't have access to generational wealth. And then lastly, access to the best education. So specifically in sickle cell disease, disparities in health outcomes include that the average life expectancy is much shorter for people with sickle cell disease compared with those who do not have sickle cell disease. People with sickle cell disease have the highest 30-day readmission rate following admission to the emergency department or to an inpatient unit. And then the rate of stroke and other complications is higher for people with sickle cell disease compared with other individuals who have matched on race and ethnicity. Health resource disparities really refer to, oops, excuse me, sorry. Okay, oh, okay, let's see what's going on. All right, so health resource disparities refer to what can be used to provide healthcare and services. And the majority of people with sickle cell disease are on public insurance. This limits their access, their choices about which physicians they can see. I'll talk in more depth about how people are made to wait longer to see a physician when they're in pain when visiting the emergency department compared with other patients. And then finally, the number of physicians trained and willing to treat patients with sickle cell disease, especially adult patients, is limited. And this further shows you what some of the age-related disparities are in sickle cell disease. This first graph shows that we expect young children to come to the emergency room when they have a fever because it can be a life-threatening complication. But the rate of emergency department visits in the pediatric years is about 1 per year on average. And then it goes up slightly as the children become a little bit older. But in the place where they move from adolescence to young adulthood, these transition years, there's a really significant jump, about 4 times as many, 3 or 4 times as many emergency department visits on average for this population. And then it stays high throughout the course of people's lives. And then similarly, the change in terms of the 30-day readmission rate, around 30%, 40% in the younger years, but then goes up to about over 60% as we move into the transition years. So there are age-related disparities where there is a lack of access to quality care for people with sickle cell disease as they age. And so then that can lead to worse care inpatient and less access to preventive care, so people use the emergency department. What's the root of this? And as I mentioned at the beginning, the root of this really is structural racism, and will become obvious, I think, in a moment. So let's think about this. So sickle cell disease affects about 100,000 people in the US, so that's represented here in the blue. Cystic fibrosis affects primarily Caucasians, here in the orange, about 30,000 people. This is the level of NIH funding in 2020. And you can see an issue right away that you have maybe about equal funding, less funding still for sickle cell disease compared to cystic fibrosis, and yet the numbers affected are so much smaller. And then when you look at philanthropic funding, the contrast is even greater. And so the average funding per affected person for people with sickle cell disease taken together is less than $1,000, whereas for cystic fibrosis, it's over $10,000. And what this does is it really limits discovery. So when you don't have enough funding, you don't have enough research on different drugs, and you don't have drugs in the pipeline, and you don't have access to curative therapies. Now, this is slightly improving, and I'll talk about that in a moment, but this is the state of where it is now, and it's been this way since sickle cell disease was first identified in Western medicine in 1910. So moving to actually defining structural racism, this definition comes from the CDC, and it's informed by Dr. Kamara Jones, where she begins by talking about how racism assigns value to different populations simply based on how they look. Race is a construct, it's a social construct. And so it really depends on what you see when you see that person. It unfairly advantages some individuals and communities, and this is an important piece about it. I think many people appreciate how it unfairly disadvantages some individuals and communities, but it also unfairly advantages others. It hurts the health of everyone because everyone isn't able to attain their highest level of health. And it can be intentional or not. It impacts health in many ways, and it drives unfair treatment. So there's a structural aspect of racism, and then there's an interpersonal aspect of racism. that I'll again talk about in a bit. In the case of sickle cell disease, that racism was recognized by the Black Panther Party in the 60s. So sickle cell disease was really fraught with discrimination, really poor treatment, really people living in a great deal of pain, dying early. And the Black Panther Party took this on in the 60s. They took on sickle cell disease as really recognized as that place where the suffering and the pain of the Black community was really held in the US. And they began to test people for their sickle cell trait status so that they would know and be informed when they made reproductive decisions. They offered free healthcare as well as to the general Black community. But they also partnered with physicians in the Black Panther Party was founded in Oakland, and there were physicians in Oakland who worked with them, but also around the country, who began to bring attention to sickle cell disease on a national level. And this fight actually bore fruit, so that funding was allocated in 1972 through the Sickle Cell Treatment Act to improve care for people with sickle cell disease. And in our area in Northern California, the Northern California Comprehensive Sickle Cell Center was established in 1975 with those funds. At the time, there were 10 programs throughout the US that featured clinical care, research, and community education. These programs were generally established within pediatric centers. People with sickle cell disease were not expected to live past about age 20, and the programs worked. So mortality in the pediatric years did decrease with such interventions as newborn screening, transcranial Doppler screening for stroke risk, prophylactic penicillin to prevent overwhelming infection. But adult care was always just an option. And we had a community hospital in Oakland that was caring for adults with sickle cell disease, and it simply closed in 1999. It was a community benefit program, and they just closed. And so the adult care was displaced. It ended up at the Children's Hospital for the adults, which is not ideal. They were able to be seen, and still are, in our outpatient programs at the Benioff Children's Hospitals, but they still have to be hospitalized in the community or go to the emergency room in the community because we aren't licensed to have them inpatient in our facility. And then further, the National Heart, Lung, and Blood Institute that had funded the comprehensive sickle cell centers simply ceased funding for those programs in 2007. So all along, public funding has been inadequate for sickle cell disease. And so where each year you see in the pediatric years a decrease of 3% per year in mortality, for adults, mortality increases by 1% per year. And really bias, discrimination, and stigmatization are significant issues. So I wanted to talk about pain and sickle cell disease, which many people think about when they think about sickle cell disease. But recall that sickle cell is very complex, and it's not just about pain. However, pain in sickle cell disease is different from almost all other pain syndromes. The onset is in infancy. So people are exposed to opioids from a very early age. They're exposed to the trauma of being separated from their family with hospitalizations. They're exposed to the traumas of pain and of medical procedures. And yet providers overestimate the risk of addiction for patients with sickle cell disease compared with other chronic pain syndromes. And our patients and families consistently report that they're discriminated against, misbelieved, and mistreated within the healthcare system. There have been guidelines established for pain and care in sickle cell disease, where it's stated that you need to determine what are the pain characteristics, what are the associated symptoms. And yet too many providers will just look at a person and decide, you look like you're comfortable, you don't look like you're in pain, so I'm not going to treat you. Further, some providers don't consider that the pharmacodynamics and pharmacokinetics of opioids may vary for individuals. Opioids, people do develop a tolerance to those medications. They may metabolize it differently. And so again, dosing doesn't depend on what you look at and decide if the person is in pain, but really what is their history and what works for them. And in a recent CDC study, they found that less than 1% of sickle cell deaths were related to opioids, compared to 3% of deaths in other non-cancer pain conditions. So that speaks to overestimating the issues with people with sickle cell disease in terms of opioid addiction and related deaths. And finally, in the early studies in sickle cell disease, it was pointed out that frequent pain, or it was revealed that frequent pain is actually a risk factor for mortality in sickle cell disease, and it remains so today. So again, we have these structural racism problems, policies, practices. Now let's look at interpersonal issues in relation to racism and how that impacts people with sickle cell disease. So in a study of more than 170,000 emergency department visit records, patients with sickle cell disease were found to have to wait up to 50% longer than other patients to be treated for their severe pain. So in turn, they report that they delay seeking care, even for potentially life-threatening events. In an interesting study, when you think about the context in this country where Black and African-American men are considered such threats to the population, in sickle cell disease, in the survey study of men and women with sickle cell disease, the men reported more that they were afraid to seek care, that they were concerned about medication errors, about being misdiagnosed. And so think about how these men that are perceived as such a threat in society themselves are anxious and fearful about the care that they might receive. Language is important. There is language where people with sickle cell disease are reduced to a label like sickler, or reduced to a label like frequent flyer in the emergency room. But in a study where interns and residents looked at a hypothetical patient, they were randomized to look at one chart that contained such stigmatizing language and another chart that contained neutral language. Their attitudes, as you can see here, when they were, when they were exposed to the stigmatizing language, they had more negative attitudes towards the patients with sickle cell disease. When they were exposed to the neutral language, they had more positive attitudes towards the patients with sickle cell disease. And when they were exposed to the stigmatizing language, they were more likely to say that they would be less aggressive in the management of the pain. And with the neutral language, they were more aggressive in their management of pain. So language does matter. And in a study that we did in our own institution, where we looked at pediatric residents' attitudes towards patients with sickle cell disease, the residents were primarily female and white, and we divided them into more or less experience with sickle cell disease, so that about half had seen more than 21 patients throughout the course of their early careers, and the other half had seen fewer, and so we labeled them less experienced. When we compared the responses to the STEM, patients with sickle cell disease overreport pain, there wasn't a difference between the less and more experienced residents, and that thinking that our patients overreported pain was low, which speaks to that these residents were embedded in a sickle cell center. But when we asked, are patients frustrating to care for, both experienced and less experienced residents started to indicate our patients were quite frustrating to care for, and not so much make them glad they went into medicine. And then there was a significant difference in their estimation of how easy our patients were to empathize with, so that the more experience that they had with our patients, the less easy they found them to empathize with. So these kinds of findings are very concerning. So how do we mitigate some of these disparities? In thinking about pain treatment, adequate pain treatment means that you have a philosophy that patients want and deserve optimal pain relief and the best quality of life. And so in the acute setting, patients need to be listened to. The gold standard of pain assessment is the patient's report. And then individualized pain plans need to be created in a trusting environment between providers and patients and families, where the patient and family are at the center of that communication. And then decisions about pain management need to be based on guidelines, not on looking at an individual and deciding if you think they're in pain or not. And then lastly, pain management protocols need to be available, and as well as individualized pain plans. Another way to improve or address healthcare disparities is to operate within an anti-racism framework. An anti-racism framework recognizes that racism is a system, and it's a system that impacts all of us. And so we have to recognize and rectify historic injustices. Resources need to be provided according to need. And in the case of sickle cell disease, there are more curative therapies available now, or it's definitely on the horizon. We can't lose sight of the fact that still patients don't have access to quality care. And so as journalists, as providers, as individuals, we need to act together to dismantle racism in structures and policies, as well as by taking personal responsibility. And so a framework that I teach our residents is cultural humility. That first, they need to reflect and understand that they need to be humble, no matter who they're interacting with, and recognize that they can learn something from everyone. Treat every person with the utmost respect and strive to preserve dignity always. Hold everyone in the highest regard, and that means understanding what are our unconscious biases that we bring to treating people with sickle cell disease, to reporting, to research. Recognize that cultural humility is relevant in each and every encounter, and that by embodying this practice, that in fact, we enhance our own as well as everyone else's resilience. So partnerships are essential to this. And I noted that the Black Panther Party, really that partnership between the Black Panther Party and healthcare providers in the community led to those changes in the 70s. And there are national efforts now that are focused on improving sickle cell disease care. The Cure Sickle Cell initiative at the National Heart, Lung, and Blood Institute that is really going to bring curative therapies more quickly but more safely into the sickle cell population. The Sickle Cell Disease Coalition is an international collaboration. The strategic plan and blueprint for action that was put forward by a panel put together by the National Academy of Sciences, Engineering, and Medicine, and the Sickle Cell Disease Implementation Consortium that is bringing bringing discovery into practice. And then in our own state of California, we brought together over 50 stakeholders in 2018 to deliberate on what are the issues in sickle cell care in California. We created an an 8-state action plan, and from there presented it to the state legislature, and it was approved and funded for 4 years in terms of better care for adults with sickle cell disease specifically, because that's what really identified. And so what I want to highlight here is that we all came together, researchers, clinicians, people with sickle cell disease, policymakers, epidemiologists. We all came together to create this plan. A newer partnership has been extremely effective on the federal level right now. And so there is a new Sickle Cell Disease Treatment Centers Act that was introduced in September, and other legislation that is moving through that we hope will come to fruition in 2023, and that there will be better sustained funding for sickle cell care. I want to remind us, however, that where this is a rare disease in the US, 100,000 people overall affected, More than 300,000 babies are born with sickle cell disease every year in sub-Saharan Africa. And the disparity is that up to 90% will die by their 5th birthday. So sickle cell disease is a global public health issue. It's a public health issue in the US, and it's something that we all need to come together to focus on. And I'd like to thank you.
I would like to thank you for that presentation and remind the journalists that one of our speakers in tomorrow's morning session is a journalist, Elizabeth Merab, who our Kenyan fellows I'm sure know, but she is also someone living with sickle cell. But now we need to pivot to our next speaker, Megan Halley, who's going to help us understand the sort of intersectional aspect of not only racism, other funding, resource access problems, but also the ethical challenges in rare disease treatment and advocacy. Thank you.
Thank you, Rachel, and thank you to the National Press Foundation for inviting me to speak with you today. Let me go ahead and share my screen. All right, so I'm going to assume that that looks okay unless someone tells me otherwise. So as Rachel said, my name is Megan Halley. I'm a senior research scholar at the Center for Biomedical Ethics at Stanford University. I'm a medical anthropologist by training, and as well as a bioethicist. And so my approach to research in rare disease really tries to take a step back and think about policy issues. And so I think Dr. Treadwell's discussion about structural racism was a really nice introduction. And I think this talk will hopefully dovetail nicely with that. Let me just make sure I can forward my slides. But before I go into that, I also always like to acknowledge that, we all have personal experiences that drive what we do and our interest in our particular research topic. And while I don't have any financial disclosures, I do have a very personal one, which is my son, Philip. I was a medical anthropologist before I was a mother, but now I'm a medical anthropologist and bioethicist who studies rare disease, in part because of my son, Philip, who is actually a patient in the Undiagnosed Diseases Network that you heard Dr. Bill Gall talk about yesterday. And while he remains undiagnosed, the need for a diagnosis and the need for diagnosis and treatment and better care for all patients with rare diseases is really where the majority of my work focuses. I also like to mention Philip in frankly all of my talks, in part because I think reflexivity and recognition about our own positionality as researchers or journalists is really important, particularly at this juncture of our current political environment in the United States. And so just another reason why I always like to start with talking about my son. So I want to talk first about rare disease facts. I'm going to get to equity, but I think it's first important to put some of this in perspective. And this is going to look perhaps a little different than some of the other slides on rare disease facts that I'm sure you've seen from other presenters. So what I did here is I pulled what I call facts in quotes from multiple well-regarded sources on rare diseases. And you've probably heard the statistic already that there are about 300 million individuals living with a rare disease worldwide. Or maybe you've heard it's 350 million or maybe 400 million. That's a pretty huge difference in terms of our estimates. You may have heard that there are about 7,000 rare diseases, or maybe you heard there were 6,000 or 8,000. A recent paper actually suggested there were more like 10,000. And in fact, we also often say that there are 250 new rare diseases identified every year, but that 7,000 number stubbornly refused to budge. We also hear different things about the facts about the rare diseases themselves in terms of what percentage are genetic. 80% is the most common statistic used, but recent data suggests that it may be lower, more like 50%. And we also hear percentages affecting children, but it's not entirely clear where those data come from. And again, I don't want to belabor this point, but the fact is that the fact is that these facts themselves are very much estimates. And my point here is not that they are necessarily made up, but that the inconsistency or variability in facts like this point to the extent to which our knowledge of rare diseases as a group is really very much at its very early stages. because we don't have a system for tracking rare diseases as a group. One of the reasons for this is that we don't track rare disease within our healthcare system. For those of you who aren't familiar with the ICD, or International Classification of Diseases system, ICD-10, which is the current system we use, only has codes for about 500 rare diseases, which means that the however many additional thousands are very difficult to track within the medical record. ICD-11, which is what's supposed to come out earlier this year, still is not out. There has been a huge push globally to increase that number, but it's a very slow process, and frankly will always be behind. And this is problematic because the ICD codes are often used in research that help us understand and prioritize at the policy level. Another significant issue is that we don't have a systematic way of naming rare diseases, and this is just a few examples. Here we have diseases that are named after the first patient who was diagnosed, or the scientist who discovered it, or maybe just the main symptom, or even an uninterpretable acronym, or of course based on the gene. But we often see a single gene being associated with a wide variety of phenotypes, as well as different severities. And also for more established rare diseases, and I include Charcot-Marie Tooth here, which is a disease that's been recognized for decades, but now that we have more access to genomic sequencing, we're finding up to 80 genes associated with CMT, which certainly begs the question, is CMT a single disease or is it 80 diseases? And then when you get into, how do you track that and how do you assess numbers of rare diseases, for example, it obviously gets quite tricky. And really what I want to focus on here as it relates to equity is our lack of an integrated approach to rare diseases in the United States and globally. Most of my examples will come from the United States, but this is not a problem that is unique to the US alone. I like to draw parallels to cancer when I talk about rare diseases to make a point, not to pick on cancer. I would hate for that to be the takeaway, but also because cancer is itself a group of heterogeneous diseases that are essentially grouped loosely by etiology or type, not that different from rare genetic diseases. In cancer, however, we are, I would say, argue well ahead of where we are in rare genetic diseases in terms of tracking epidemiology and outcomes. This slide here is for the Surveillance Epidemiology and End Result Program, which is a program from the NIH and CDC that tracks outcomes and allows us to understand, among other things, where the greatest need is or where the greatest burden, and at least theoretically to prioritize based on some sort of objective criteria. Fortunately, in rare disease, it's not necessarily, in rare disease globally, I'll talk about specifics within rare disease, but globally compared to other disease groups, it's not necessarily money. We actually spent in the ballpark about the same amount on rare diseases, 6.5 billion in 2021, as we did on cancer, 7.6 billion. If you haven't already been presented with the statistics, the number of rare disease patients in the United States alone is estimated to be approximately equal to the number of cancer survivors alive at any one time. So we're talking about, in terms of overall prevalence, somewhat similar numbers. But for cancer, everything's organized within the National Cancer Institute, whereas in rare disease, we have the Office of Rare Disease Research within NCAT, which is quite a small institute itself. We have National Human Genome Research Institute, but again, that's a small institute. And so we have this funding spread out all across the various NIH institutes. And I think this really points to the lack of a coordinated system for prioritizing and funding research and therapeutics within rare diseases in the United States as well as in other countries. So what has happened instead? And I'm really happy that Dr. Treadwell talked about the example of sickle cell and CF. It's actually in my presentation as well, so I will go over it briefly. But without this systematic system for prioritizing and understanding rare diseases as a group, we instead rely essentially on patients and families to drive research. Certainly you would never imagine turning to a child or parent of a child with cancer and saying, your child has cancer, I'm so sorry. All you need to do is to get treatment is create a foundation, raise a few $1 million, find some scientists, organize with the FDA, and maybe in a few years you'll have a treatment. But that's what we do in rare diseases all the time. And we have seen some incredible successes. I do point to this book, Breath from Salt, as an example of CF, taken from CF, the CF Foundation, specifically the Cystic Fibrosis Foundation, where this foundation together with a lot of support from the federal government has taken a disease that was earlier last century, deadly in childhood, to one that's by many accounts on the verge of a cure. But this is not necessarily a unique, while the CF Foundation has been incredibly successful, this is really our de facto system in rare disease. And I provide just a few examples from the media, because this is often where we're hearing these stories of families who are, if it's, the Mila and her N of 1 treatment, or the Might family and everything that they did to find other patients with the same disease as their son, with the same disease, Engelai-1, as their son, Bertrand, or more recent stories about a father who started his own lab to find a treatment for his daughter, or the Carmichael family above in the middle that has started their own company. And these stories abound in the media. I will say every week I see at least one come across my feed. However, and in isolation, one of the things I want to emphasize, that in isolation, each of these stories is inspiring, and I understand why journalists are attracted to them and like to highlight them. The issue that I want, and this is where I want to transition to talking about the equity implications, is that almost invariably these families are highly educated, have high income, and have otherwise, extensive resources in terms of social capital, and so as a system, so when we leave our system to essentially those who are able to access resources and drive research, we end up in a situation where, like the one that Dr. Treadwell presented, and this is just additional data from the same paper that she showed about the difference in the number of patients with sickle cell versus CF in the United States, the disproportionate impact on different racial and ethnic groups in the United States, as well as huge differences in terms of funding and outcomes for research. And so I love this example because I think it takes what is otherwise kind of a piecemeal system and demonstrates the systematic impacts of that system in the context of rare disease. But there are also other examples I'd like to point to. I'd like to talk just a moment about newborn screening. I believe you had a presentation on that yesterday, and so I'm not going to go into the details, but I'm happy to take questions on it. It's a wonderful program, and it's often promoted as a solution to disparities. And because it is a universal program, it's kind of one of the only forms of universal healthcare you could argue we have in the United States. However, there are a number of equity concerns if you dig deeper into this program, including getting onto the recommended universal screening panel, or the RUSP for rare diseases, requires all of the connections and treatment, development of research, and ultimately a treatment that relies on the system of individual patient groups advocating for research. And so we see disparities in terms of what diseases actually end up on the RUSP and are able to be screened for. We also see variation in uptake of recommendations by state, and particularly by state budget. And so, as you can imagine, patients and communities with lower overall income tend to live in states with smaller state budgets. So we see less uptake of screening in these states. We also see higher rates of false negatives in non-white populations, which is something that I'll talk about in a minute as it relates to diagnosis in genome sequencing. And then, of course, newborn screening exists within our current healthcare system with all of the built-in structural racism that Dr. Treadwell talked about. And this data is still not out in publication, but has been presented publicly a number of times from the American Public Health Laboratories, where they did a study examining time to diagnosis as well as time to accessing treatment for patients with a positive newborn screen, and looking at that by race and ethnicity, and found that non-white populations were on average 2 weeks later in getting a diagnosis, and additional 2 weeks later in accessing therapies. And for many of the newborn screening conditions, time is of the essence. And so, a delay of a full month in terms of getting access to therapeutics can have long-term consequences. There are also huge issues in terms of access to diagnosis. Genome sequencing has been a hugely valuable tool for diagnosing rare diseases. We're seeing diagnosis being able to happen earlier, and very rare diagnosis being able to be caught that otherwise patients and families would spend many years trying to find in terms of a diagnosis. But this system also does not work equitably for patients and families, in that we see higher rates of variants of unknown significance, particularly in non-white populations. And I can't be sure, but I suspect that the issue of diversity in genomic databases and the extent to which the majority of those patients are patients of European ancestry has already been raised in this panel, but I'm happy to talk about that more if not. We also see variation in access to sequencing in terms of coverage and reimbursement. And so we have research being used as a backup in many cases for patients with undiagnosed rare diseases, including the program, the Undiagnosed Diseases Network that Dr. Gall talked about yesterday. There are many equity issues that I don't have time to talk about, but I did recently publish a paper in Nature Genetics on the topic if you're interested in access to sequencing and equity issues there.
Would you please put that in the link to that, either in the chat or send me an email with that link?
I'd be happy to. And so as a result, we see research being essentially this backup for under and uninsured populations. And then there's also a question of access to the downstream benefits of diagnosis. So even if we can get patients equitable access to diagnosis, it's not clear that they're able to equitably benefit. And I was really curious. This is some data that is not published yet as well. It's under review, but from a systematic review that our group did, we were interested in trying to understand who we were asking about the value of genome sequencing. And are we actually even asking a diverse group of patients and families what the impacts are for them? And so this is a systematic review of all of the papers published on the perceived utility from the perspective of patients and families of a genomic diagnosis. And what we find, and I know there's a lot here, but what we found is essentially these studies are grossly disproportionate in terms of representing well-educated, primarily white, primarily women with high income, bachelor's degrees or graduate degrees. And the extent to which those families are able to perceive and appreciate benefits from a diagnosis is almost certainly going to be quite different. In fact, in our study, I think the most striking statistic was almost half, 41 of all Black participants in qualitative studies came from a single study that was specifically focused on Black participants, Black patients. And and that study in particular, was a study. The title was something like, African Americans' perspectives on genome sequencing. But we came across dozens of studies that were predominantly or exclusively white patients, but none of them stated in the title perspectives of white patients on genomic sequencing. It was, and in doing so, I think really reinforced hegemonic norms around whiteness being kind of the normal, and continues to other Black and other minority perspectives. And then just to wrap up, I want to talk a little bit about cost of therapeutics. I'm sure this has been in the news recently. In particular, while the advances in genomics and molecular biology, new drugs in terms of cell and gene therapies, and antisense ASOs, I can never say oligonucleotides well, in just the last 5 to 7 years have been really quite stunning. And in just the last few months, we've seen a number of high profile new gene therapies come to market. But one of the characteristics that we see in each of these stories is essentially each drug breaking the price tag record of the drug that came before it. So we started with Spinraza for spinal muscular atrophy in 2016. At that point, that was the most expensive drug on the market. That was followed by Zolgensma, also for spinal muscular atrophy, at over $2 million. That was the most expensive drug in the world at the time. And just recently, we saw Bluebird Bio come out with 2 different new gene therapies, one for beta thalassemia and the other for cerebral adrenoleukodystrophy, or CLD, breaking its own record, one at a time. The payers, the pharmaceutical companies argue, there's high development overhead, this is for a small number of patients, and that particularly for the gene therapies, there's potential to offset the lifelong costs of care for patients with severe disease if this gene therapy indeed is a cure. But of course, these high costs raise a number of very complex ethical questions for the healthcare system, as well as for patients and families. One of the things we see is state governments raising just frankly frantic concerns about the impacts on Medicaid budgets, and literally breaking state budgets, or in the case of the University of Washington, talking about having to shut down a center of excellence because its state budget simply cannot handle all of the patients with spinal muscular atrophy that they anticipated coming for treatment in that state. It serves a particularly large catchment on the West Coast. But one of the ways that Medicaid programs have dealt with this is by limiting the eligibility criteria well beyond what the FDA allows for. We also see them, programs, both public and private insurers, tying up families for many months in coverage disputes, during which time the child's ability to benefit from the drug often declines. And this is data from a recent analysis of Medicaid coverage policies that essentially found that the more restrictive the policy, the lower the utilization of these expensive drugs in the states, suggesting that patients and families simply aren't able to access them in the way that they otherwise should, based on the national approval from the FDA. And then the other piece that I just want to make sure to make a note of, and I don't like that this is at the end, but I think one of the things that we need to keep in mind when we're thinking about these high-priced drugs and how they're impacting patient communities is that disability is also an important component of equity and access, in addition to issues of race and ethnicity. And for these new drugs, we need to keep in mind that there are a diversity of perspectives. And this is a quote from a patient from a paper on patient perspectives on the new drugs for spinal muscular atrophy. And this is an adult patient who's really expressing frustration at the focus on therapeutics as being particularly ableist, at least from their own personal perspective, and pointing out that the $8 million, which is what they estimated the lifetime cost of Spinraza treatment, they could meet all of their needs and then some. But those are needs that currently their insurance companies fight them on. So they're willing to pay for Spinraza so that, as this person says, they'll be able to open a Ziploc container, but they won't cover any of the resources that would actually allow them to have a full life as a person with a disability. And so I think that this is also a very important perspective. I think there often is a focus on children, but many of these diseases, particularly as we are seeing advances in therapeutics, are going to grow into adulthood, and many already do. And so I think thinking about disparities in terms of access and care for children versus adults, and making sure that we're thinking about not making assumptions about what individual patients and families value and what their needs are is going to continue to be very important. And so I just want to wrap up by saying that I think that there's increasingly an emphasis on rare diseases as a public health issue, but I think public health problems need public health solutions, as opposed to what we're currently seeing, which is a system that allows those with their own personal means, or when their community has means, to move therapeutics forward, and primarily a reliance on private industry, to partnership with private industry to do that. And I would love to see more leadership from the federal government and from the NIH to develop a more systematic approach to rare diseases. And that's it. Thank you.
Once again, another presentation where we need another hour with both of you to unpack and to really get at these things. But unfortunately, our time is running out. And so I'm going to just do a few things. One is to let Megan know that Bijal Trivedi is one of our fellows this year. So we all got a kick about you shouting out her book during your presentation. But also Portia Gabor of Ghana. Are you still on, Portia? If not, we need to let Portia know that Marcia is headed her way. And so hopefully those two can connect at some point. But the point being, I think the most powerful, well, there's so many, but one of the most powerful things that I just heard was a lot of the coverage that we see about rare disease is in fact very powerful. It's very inspiring. It's very sort of wow, but it's about people with resources, with education, often a lot of funding, a lot of money, the ability to do that. So I think our challenge as journalists, the next plateau is going to have to be normalizing rare disease and making sure that it's not just something that the 1%ers, if you will. I know that's a stereotype, and I don't want to put it in that category necessarily, but we have to make sure that more of the experiences of people and families who are dealing with it are reflected in our media. So one thing I'm going to ask for both of you is, one of the things we've been doing when we run out of time is we allow the journalists to send us their questions by email. And if we can forward them to you, if you have time at some point, if you could answer them that way, that's the way we're going to have to be able to deal with this, because we've got to try to keep on schedule. But Megan Halley and Marcia Treadwell, thank you so much for joining us today and sharing these insights with us.
Thank you so much.
Thank you so much.
Have a great rest of your meeting.
Okay, bye-bye.
Bye-bye.